Good morning. My name is Tony Gillespie. I am the Vice President of Public Policy and Engagement here at Indiana Minority Health Coalition.
And my name is Lancaster. I serve as the Maternal Child Health Manager here at IMHC, and thank you all for joining us today.
Absolutely. I've been with IMHC now in October, it will be 25 years. And in those 25 years, I've seen the agency grow tremendously. And Lauren, you've been here now
through almost 3 years in November.
And in almost 3 years, she has done incredible work towards the idea of developing a maternal child health division. Which I think is new territory, not only new territory in the issue, but new territory in sort of building a new division here at IMHC. So a lot of growth and I think opportunity in that area. But let me get back to the story I'm supposed to be telling. The way IMHC became part of this maternal child health effort, historically, infant mortality has always been an issue across the country and disproportionate impact on racial and ethnic minority communities in Indiana that is largely Hispanic and African American. And the most disparaging numbers, the largest numbers, are among African American families. So infant mortality had always been part of our warehouse in terms of chronic health conditions or disease that we addressed across the state. Mid 2000s, we began to see an emergence of maternal deaths. Maternal death, either pre-delivery, during the what word is that? What am I looking for? During the prenatal period. 25 years, 3 years old, not old. During the prenatal period or at delivery or up to 1 year postpartum. And so as the numbers climbed across the country and there was this emergence that, comparatively the United States had the worst numbers of any organized developed country in the world. And so the United States, we also have the most expensive health care in the world, so there really began to be a disconnect. And in the maternal death, it was racial and ethnic minority communities, primarily African American women who were dying. And as more and more information became available, it was Indiana that was number 3 on the top of the bad list in terms of our maternal death rate. And for one of my things that I always say that here in Indiana, we are always at the top of the bad list and the bottom of the good list on so many chronic health conditions. And in that being top of the bad list is racial and ethnic minority communities that carry the burdens that make up most of the numbers. So as we began to see that and it just became alarming, we put together our annual luncheon. We've been doing our annual luncheons for the last 28 years. And COVID, we had to do some different things, but the luncheon that we pulled together, we brought in Judge Glenda Hatchett, TV judge, who her son a few years earlier had lost his wife, second birth, healthy mom, healthy baby, but she died during the postpartum period after she gave birth. And as more and more information emerged, it was, a healthy combination of racism, healthy combination of, as a black woman, she was deprioritized, and it gained such national recognition and became a conversation across the country that the story has been told on various television programs. It just became a cautionary tale. And so with that luncheon, that really began, that was our way that we did something big to call attention to the fact that black women were dying at exponential rates for the cause of having a baby. One of our legislators, State Representative Vanessa Summers, who's part of the Democratic caucus, but she's also an employee here at IMHC. And the way she coined the phrase was, women are dying just because they got pregnant in Indiana. and it was just such detrimental, and the stories began to emerge. And so, we decided that we really need to do something more formal, not just a one-off, not just do a luncheon and release a video and hand out some flyers, but we really began to formulate the idea of building a division that addressed both infant mortality and maternal mortality, and sort of coined the phrase or the idea that the best outcome, or the best health outcome or birth outcome, is that mom and baby leave the hospital together. You don't want a mom to go home without a baby. You don't want a baby to go home without a mom. And that's really how we began to build it. We worked with the late, great Senator Gene Breaux, who had the idea, let's do Medicaid reimbursement for doula services. Just a short historical piece of doulas in America. In the early 1900s, doulas were just a part of giving birth in America. That was both for black families and for white families as well. There are many, many people that I know I've run across that said, "Oh, a doula delivered me," and so it's just part of the culture then. Over the years, that dwindled for a number of reasons, and so in terms of looking at what would be an effective intervention to slow the death rates for black women, for all women, but specifically targeting black women because that's where the higher numbers were. Senator Breaux wanted to create a doula program where there was Medicaid reimbursement. And so we began that, and we testified and supported it both in House and Senate. It passed, and then it became a law. And then the momentum kind of stopped because they didn't put any money, they didn't assign a budget to it. And so there were just a lot of stops and starts along the way. When we began to work with other states, Indiana was sort of in the spotlight because we had passed that legislation. Which is great, but for me, participating in national conversations of, oh, Indiana's on the line, Indiana's done such incredible work, and I kept thinking, ooh, if Indiana is above the fray, what? Nothing is happening in other states. But it was some peer recognition, peer support, and then we began to learn that California was doing something about it, and Massachusetts was doing something about it, and other states. The pandemic changed a lot of that, the momentum, but what ultimately ended up happening is that the Indiana State Department of Health reassigned 2 grants that they had given for doula services. And that was doula services in central Indiana, South Bend, Elkhart, Logansport, Michigan City, and over the last couple of years we expanded it to include other counties in central Indiana. And that's where the higher rates were in a disproportionate frame. The numbers were higher there. And so we got a doula program up and running, and it was assigned to me. We hired doulas, we did a lot of community education, and we got the program moving. But at the very beginning, I shared with the leadership at IMHC, this is great, I'm willing to do it, I'm passionate about it. I can't be the face. I'm a black man, I'm not a dad. For me, it just is, it's personal, and I'm passionate about it, because during that time, as the more death occurred and the numbers were growing, that's when all of my brothers and sisters were having their children, my nieces and nephews. And then you started to hear stories. One of the most compelling national conversations was that for my generation, my mother and her mother were safer than women now. Giving birth was safer for them. So I was born in 65, my mom was born in 45, my grandmother was born in 29, and so, with all of the technology and all of the advances in medicine, period, but certainly in giving birth, they were much safer than women now. So that was just frightening to me. And then you began to hear stories, family stories. My mom had preeclampsia that wasn't diagnosed or detected until she was given birth. Her blood pressure shot up, my baby sister's blood pressure shot up, and they almost lost them both. Those are near misses, but those are stories that you don't necessarily hear or talk about, because especially from an African American family standpoint, the focus is everybody's still here, it was okay. So those stories just get lost, not because they're not important, but because you focus on moving forward and life. And so it just became so important that we do something about it. And so in building what is now the Maternal Child Health Division, I'm just going to say it, that's what it is. I'm claiming it. I just, I said I'm not the right face, and we really need to bring in a different voice and a different face to move this along. And we had discussed some other ideas and initiatives, but we built this doula program, and then after a national search and after hundreds and hundreds of candidates, we found Lauren Lancaster. So I would love for Lauren Lancaster to take it away.
Yeah. So as Tony mentioned, we have a doula program. So our doula program is called the Community Doula Services program. So we hire members of the community to be doulas, which I think is a testament to the program. To have community members that live in the area that they serve, that know individuals and resources, is vital to our program. So Community Doula Services, we currently again service St. Joe County, Elkhart County, LaPorte, Howard, Miami, and Cass counties. And we have a diverse group of doulas who are bilingual English and Spanish, as well as bilingual Haitian Creole and English. And we target pregnant women between the ages of 15 to 35 who are Black and brown, and who would be eligible for Medicaid or do have Medicaid. And the program is completely free for them, and they can enter our program at any stage of their pregnancy and even postpartum, which I think is another great tool or initiative that we have within our program. And then clients stay in our program until their baby turns 1. And even after their baby turns 1 and they graduate, they often still contact their doulas because they've created this relationship for almost a 2-year span, or at least a year and a half, depending upon how long they've been in the program. So within our program, we offer different resources and different items, I would say, for our clients. So whether that is baby bags, diapers, menstrual products, onesies, bibs, because we know that these items cost and they're very costly. So we try to limit the financial burden that's put on our clients. And so one of the recent things that we initiated within our program is our menstrual program, where we know once you have your baby, your cycle is going to reappear, and menstrual products are not cheap. So we are able to provide our clients with tampons and pads and other products that are necessary for them as they take on that financial burden again with having their cycle. And so our doulas do a great job in connecting their clients to resources. They also double as community health workers. So they are able to offer referrals to their clients, such as needed services such as mental health, food banks, as well as if our clients or their partners are looking for jobs. Because our doulas live in the community, they know of different companies that are hiring. And to back up a little bit, a doula is a non-medical support person. So oftentimes doulas can be confused with midwives, in which midwives are medical support people that can deliver babies. So doulas are there to really provide support for their clients, such as informing them and educating them on their pregnancy journey, what that would look like, as well as labor and delivery and postpartum. They help with stretching, and they help with advocacy. So I know a number of our doulas serve as advocates and teach their clients how to be advocates, not only for themselves, but for their babies that they will be having soon. So I love the work that we do. We try to offer culturally congruent services to ensure that all clients are being met where they're at. So that's one of the reasons why we hire bilingual doulas, especially in the Logansport area, which is a rural town here in Indiana, where there was an increase of Haitian Creole individuals coming to work there. And so we said, hey, we need a Haitian Creole doula. And so we have great doulas who are bilingual there and that really provide great services to those community members. But not only in this department do we do doulas work, but we also do a whole host of other things, such as we've partnered with Indiana University, Indianapolis, to host the Black Maternal Health Echo, which is a year-long series in which we educate individuals not only here in the state of Indiana, but also 39 states and DC about topics related to Black maternal health. So those topics vary around racism in the medical field, stillbirths, preeclampsia, food access, and a whole host of other topics.
Right. Near misses.
Near misses, yeah. Innovative efforts that are being done around the country to address these issues. So it really gives us the opportunity to meet and discuss and talk about these topics so that we can continue to go out there and educate our attendees.
And the thing with our ECHO, the ECHO, our Black Maternal Health ECHO, is really designed to create a platform for healthcare workers, clinicians, physicians, nurses, and we expanded our provider scope to include other birth workers, doulas, social workers, case managers, program managers, because it's a whole cast of services that, from the start of pregnancy to that postpartum period and 1 year beyond and even beyond that, it's a whole cast of providers. And that in terms of looking at the root cause of maternal death, education among physicians is part of an education, not education on how to be a doctor, but education in how to be culturally inclusive and congruent in serving a diverse medical population, or diverse patient load. And the numbers speak for themselves. It's Black women who fare the worst health and birth outcomes. And so our ECHO is designed to bring in education and information to address that issue. So the idea is the ECHO, we just target clinicians. That's Black clinicians, white clinicians, Hispanic, it doesn't matter, because what is clear in the numbers and the research and determining the root cause is that so much of this is race and ethnicity and culture. And of course the medical piece is important, but you really, being understood and receiving services that are appropriate for you is inextricable to the medicine. And that's just things that we've learned over the years. So, okay, I'm sorry for the interruption. And now, Lauren, that you've taken over the program and are just really building, you're the lead in building this maternal child health, this maternal child health division that has been envisioned. Now that these services are available, what does a new mom go through? What is her experience in trying to access doula services?
Mm-hmm. So in terms of trying to access doula services, there are a number of routes that a new mom can go through to try to get doula services. So they can just do a simple search online, put doula in the city that they live in. If they are a individual that lives in the counties that they serve or that we serve, they can go to Community Doula Services, which is our site, and they can simply do a referral, or we also take provider referrals. So if they inform their provider about our program, and the provider decides or inputs a referral, they can always do it that way as well too, in order to get services.
And as we continue to build this program and we have more and more women, more and more expectant families that we serve, what are some of the standouts in terms of the impact of the doulas in this program, but both good and bad? What are some of those standout stories you think?
Yeah. So just in general, there is research that backs doulas. So individuals that have a doula are less likely to have a C-section, less likely to use Pitocin, overall better satisfaction with their labor and delivery and pregnancy journey, and then there's increased rates of breastfeeding that individuals see if they have a doula. So within our program, we also see that. So we see an uptake in individuals breastfeeding, as well as we see a overall greater satisfaction with having a doula in their labor and delivery process. And then in terms of advocating, this is probably not a quantitative or more of a qualitative approach, is that we see that our doulas have a great effect in advocating for their clients, as well as teaching their clients how to advocate for themselves and for their babies. In terms of
She's smart.
in terms of negative, and I always say it's more of a lesson,
Right.
is that as the state becomes more culturally diverse, ensuring that organization hospital entities are providing culturally congruent services for those individuals, such as providing translators, which are federally mandated to do, but ensuring that they are actually giving access to those individuals, patients, to have those services, because there's only so much that a doula can do, and a doula is not oftentimes a medical interpreter.
Right.
And we don't want any doulas to be put into those positions where they have to do that. So ensuring that hospitals are providing those services so that their patient and the doula's client can have the best possible experience that they can.
I think that is so important, and it's great that that happens because, so often, and the Indiana Minority Health Coalition exists for that very reason. So much the race and ethnicity and the cultural part of the piece in healthcare, just across the board, any health condition, so much of that is often lost, and that is I think a number of inputs. The lack of I think always understanding and honoring that culture has to be a part of serving someone. As human beings, just because we're all black doesn't mean we've all had the same experiences, doesn't mean that we need or require the same care and treatment and support. And as so with black, white, Hispanic, Asian, everybody needs something different, and that has been slow but certain emergence around the state, and that's the kind of work that IMHC does. And I think another thing to point out when you were talking about the benefits and the impact that doulas have on moms in terms of helping them advocate for themselves, or stepping in to be the advocate if there's something that's occurring at the hospital during the delivery process that doesn't support mom in her birthing effort. And working with partners around the state as we built this, around the country as we built this program, we spoke with a doula in Detroit, and she said for doulas, for healthcare providers, the point that we always have to make when a mom goes into labor and the labor and delivery team meet her, they generally have met her, they're meeting her for the first time. And so that means between the nurses and the doctor, and this is it's not a slam, it's just a fact in putting together a team that provides the best care for mom and baby. The doula is the one that has the most history, a rapport or relationship that exists, and knows what mom's triggers may be, knows what her familial situation is, whether she's married or single or has a support system, what her medical journey has been, what some of her triggers are, and building a labor and delivery team that has all of that is so important. And I think that's what our program helps weave that. And so often our doulas have to call on personality, existing relationships, and their own personal history to help make that happen. Okay, that was my interruption.
You are good. So I also want to discuss our legislative efforts, because we kind of hit on all points, whether that's providing doula services or educational programming, and then you are heavily involved with legislative work with Representative Vanessa Summers and other legislators here in Indiana. So what has been a sticking point for you in terms of educating legislators on maternal child health and the crisis that we're having nationally and then here in the state of Indiana?
Um, a sticking point. I can narrow that down in just one. Um, a big issue for me is that, and it's the same in any other state, but I know more about Indiana because I've lived in Indiana all my life. It takes us forever to get anything done. We historically, were the leaders in terms of passing this legislation for Medicaid reimbursement for doula services. But then it just kind of sat, from 2016, 2017 till now. There was no budget put to it, no structure from Medicaid in terms of how this process occurred. And that was a real issue. And the fact that there's always had to be, whatever you do to address a chronic health condition, we have to package it and address it 20 times more to convey the minority voice, to convey the minority impact, to convey that this is an issue, and providing a service that the culture and the ethnicity is not built in just becomes another service. And then you get into the access issues, and then you get into access and resources at the community level, and reimbursement, and it's going to cost, and so that's always been a major issue for me. But where we are fortunate in Indiana, we have the Indiana Legislative Black Caucus. Indiana Minority Health Coalition has always been bipartisan. So in this effort, as in all of our efforts, we have great support across the aisle, Democrat, Republican. We have some fighters and some folks that understand and appreciate this issue and are working to make it better. State Representative Vanessa Summers launched a maternal health caucus in 2021. And the idea behind that caucus is to look at the issues, to see what legislation might be needed or considered to make this issue better, because throughout all of this incredible work, Indiana is still number 3 at the top of that bad list. And so really just beginning to get some real footing and momentum and chopping that down and beginning to change those numbers. I think a celebration is with our doula program. While there have been a number of very difficult and disparaging situations, we've not experienced any maternal or infant loss among our caseload, which is significant. Another sticking point is that, and again, I'm calling out Indiana because I only know Indiana. And so around addressing the maternal health issue just across the board, a contributing factor when you look at root causes is often substance abuse, opioid addiction, which is a huge conversation around the country, around the world, and so many restrictions were put in place in terms of pain management and who can have access to important medication to manage that pain. So the idea that the most important thing that we need to address in this maternal health crisis is substance abuse. So a whole program was created around opioids, treatment for opioids, how to get you off opioids, how opioid addiction starts, and that does not speak to the entire population, or that doesn't speak to all expectant families. For African Americans, for blacks, opioids, we don't see ourselves in that crisis. For us, it's drugs. And so, those are the kind of things, because the opioid rates during pregnancy don't speak to the inclusion, or that it's a major significant impact on Black and Hispanic expectant families. So really, going back, we're going to have to go back and sort of redefine, I think, and so we're having a different population, and that's something that's happening across the country. And then funding, it's just never enough funding, and there's so many priorities and so many things that we have to do. And while I love to get mad at Indiana, the Indiana General Assembly, they truly have that for the organization and our mission and the work that we do. We've pretty much experienced significant support for as many years as we've existed, and so many of those legislators, leaders who are still with us now or retired or are no longer with us, transition from time to eternity. Along the way, it's important that we tell those stories as well, and that we acknowledge that. And it's just an inextricable link between policy and research and providing services and building services that are appropriate and congruent, as you said. Still an ongoing effort, but I think what's also important, that people my age who have been part of this for 25 years have to acknowledge the fact I am old, and it's important that we start to build these relationships. And so it's a transference of information and the historical piece, and then we bring in the knowledge and the energy of, say, you. And I said it before, and I just want to say it again. It's so important. I'm passionate about it, but I'm never going to be in that situation. I don't have children, and it's important that women, and in this instance African American, Hispanic, and Haitian women that are disproportionately affected here in Indiana, that we create a space for those voices and those stories. And I'm saying race and ethnicity, one, because that's what we do, and that's where the disproportionate impact is. But because we've not passed significant legislation, I think interventions that are changing the course of what we do, it's not just black and brown women that are suffering, it's women across the board. And so in Indiana, we lose a number of women, white women, black women, Hispanic women, Haitian Creole. We lose them to maternal death and preeclampsia, the causes, preeclampsia and hemorrhage and those other things. So that's the kind of stuff that bothers me and keeps me up at night. And exactly what pieces do we put in place to make all of that happen at the same time. And I think we're headed in the right direction, and we're always open to reset or mid-course adjustment. That's what we love. Well, that's what I love to say. Years ago, a partner that we worked with, she said, okay, you didn't lose it. We're not throwing the baby in the bathwater away. This is just a mid-course adjustment. So we're constantly, I think, adjusting and readjusting and looking at new services, or looking at discontinuing some service that's not working. That's how you serve your community, and creating a place for community voices. I always say, you cannot, this is public health. Public health cannot exist without you can't provide services and don't include the public in that plan. And so just, needing to get better and better and better in doing those things. Okay, that was a lot. But
I don't know if we want to touch on this, or this might be a later topic, but we've also recently added a maternal child health postdoc to do more research in the maternal child health area.
Did we?
Yeah.
No.
I don't know if you want to talk about that a little bit, about kind of where we're headed in that direction with being a stronghold in this state for pushing out MCH research.
Yeah. IMHC is so fortunate. We have a real bona fide research arm. Our racial and ethnic minority, racial and ethnic minority epicenter. And in that, we've done community-based research for years, looking at heart disease, looking at nutrition, looking at lack of access to healthy foods, HIV, hypertension. We looked at a number of issues from a research perspective. The MCH part, the maternal health piece, the infant death piece, those are all important. And while there's national research that exists that shows impact from a national perspective, research and policy is an inextricable link. And in Indiana, we're unique that we're in a position that when there's an issue, we can not only cite research, but we cite research about Indiana. And that tells a very different story, I think, to a legislator, that we're not just talking about women across the country, or this piece. Well, this actually is Wyoming. We're talking about Indiana. And so we were fortunate enough through a partnership with one of our managed healthcare partners. We now have a postdoctoral fellow who is part of the staff here at IMHC, and her role will be to mount research projects and to release information that speaks to Indiana, that speaks to the maternal health crisis, infant mortality. And it's also an opportunity, I think, for us to partner with other entities to be part of some national research as well. So I am super, super, super excited about this. Sometimes, excitement is a great thing, but then you start running your mouth, and then the next thing you know, you're stuck with it. But I'm blessed. I'm blessed to be here, and so we now have a postdoctoral fellow, Dr. Aisha Adewaye, and she's going to be working with research partners around the state, around the country. We have an incredible team of mentors that she's working with. Dr. Beth Meyerson, who's formerly a Indiana resident and a researcher and professor at Indiana University Bloomington. She's now in Arizona. Dr. Jasmine Johnson, who's a young African-American OBGYN that is from the state of Indiana. A little more information, she's actually from the region, which is where I'm from, Northwest Indiana. Shout out 219. And she's part of our mentoring team, and she's also part of the ECHO that you mentioned earlier. And then former Surgeon General and former Indiana Health Commissioner Jerome Adams. And we really think that this will provide, I think a diverse public health research support for our postdoc. And then we have the benefit of these three very different public health giants, and so I am just so optimistic and so excited about this opportunity, and to really do some projects that where we're able to help families, expectant families, tell their story. Good stories with great outcomes, challenging stories that our outcomes weren't so great. And then stories on how we can do better or do something different. That's what I'm most optimistic about with this. So thank you for mentioning that.
No problem at all. So that is a little bit about our MCH department that we have here. Division, my bad. Division that we have here at the Indiana Minority Health Coalition. We hope that you guys learned a lot of information about the great work that we are doing and will join us along the way.
Absolutely. Thank you for your time here with Minority Health Matters. I'm Tony Gillespie.
And I'm Lauren Lancaster.